Good morning, everyone. It's truly a pleasure to be part of this masterclass session. Today, I'll be taking you through a topic that often looks very technical at your first glance. That is, I'll be discussing about the FACEBOW and the programming of the articulator. I still remember the first time I encountered a FACEBOW as a student. It honestly looked like a complicated headgear straight from a sci fi movie. But once I understood its purpose, I realized it's actually one of the most powerful tools we have in prosthodontics. And for all the PG students out here, this just isn't a theory topic, but it is one of the most important exam oriented topics. In fact, your entire practical exam revolves around these steps, and every single aspect of this topic is important for your chair side viva. That's why throughout this presentation, along with discussing about the FACEBOW and the programming of articulators, I'll also be highlighting certain commonly asked Viva questions. So do listen carefully to the slides because those little details will often make the biggest difference in your exams. So these are my table of contents. To introduce to the topic, the craniomaxillary complex, which consists of the cranium plus the maxilla, articulates with a one single moving bone, which is the mandible. Now, the TMJ is often described as a diarthrodial gyngimus joint. Now, this is because it is capable of two types of basic movements, which is the sliding movements and the hinge movement. Now, when a person's mandible moves, as it does in carrying out the functions of the mastication and the speech, the various movements it makes and the relationship it assumes defy the description because of their complexity. As you can see in this video, here the mandible is moving on an arc of a circle with a definite radius from the temporomandibular joint. Now, the maxillary anatomy and the TMJ varies from person to person, and so it has to be determined for every individual patient. That is, the relationship of the maxilla to the opening and the closing axis has to be determined. Now, you all must be wondering why FACEBOW, why articulator? Now, a harmonious occlusion isn't just about the teeth which is touching. Along with the teeth touching, it maintains the health of the supporting structures, the muscles, the TMJ. So if this harmony is disturbed, everything from your periodontal health to the muscle balance and the joint comfort, everything is affected. Now, this is how our mandible moves. That is from maximum intercuspation to the hinge opening, to the maximum opening, maximum protrusion, and then finally back to the intercuspations. And this is popularly called as a Possel's figure. Now, he investigated and came out with this envelope of motion, and also mandible has intra-border functional movements. Now, as you can see in these series of animations, that the mandible doesn't just move up and down, but it has a complex 3D path which is unique to every patient. And that is why it's very important for us to accurately transfer the movement of the mandible, so that when we develop a new occlusion, it is developed in such a way that your health of your supporting structures, the orofacial musculature and the TMJ is maintained. And that is why there is a need for accurately locating the hinge axis and recording and transferring the same on the articulator. Coming to the terminologies, jaw relation is defined as any spatial relationship of the maxilla to the mandible and any one of the infinite relationship of the mandible to the maxillae. And jaw relation record is defined as a registration of any positional relationship of the mandible relative to the maxillae, and these can be made at any vertical, horizontal or the lateral orientation. Now, in an edentulous mouth, maxillomandibular relationship is divided into orientation, the vertical and the horizontal type. Now, all this together, these three relations will help us determine the height of the dentures and the way they are related to each other. Now, orientation relation refers to the establishment of relation references in the cranium. The vertical relationship gives you the amount of jaw separation which is allowable for the dentures. And finally, the horizontal relations establish the front to back and the side to side relation of one jaw to the other. So considering in these manners, the relation of your mandible to the maxillae or the cranium can be accurately determined in 3 dimensions. So here what is important to us is the orientation jaw relation. Now what exactly this relationship is, it can be clearly depicted in the in the image which is displayed. So these are those that orient the mandible to the cranium in such a way that when the mandible is kept in its most posterior position, the mandible can rotate in sagittal plane around an imaginary transverse axis which passes through or near the condyle. So what is FACEBOW? The FACEBOW is the caliper-like device which is used to record this relationship of the jaws to the temporomandibular joints or the opening axis of the jaws and to orient the cast in the same relationship to the opening axis of the articulator. Now the FACEBOW will help in locating this axis, and it is also used to record the anteroposterior and the mediolateral spatial position of the maxillary occlusal surfaces relative to this transverse opening and the closing axis of the patient's mandible. So once we understand the definition of a FACEBOW, we can simplify its purpose into 3 words, that is locate, record and transfer. That is, first we locate the hinge axis, second we record the patient's unique maxillary relation, and finally we transfer it to the articulator so that our lab work will truly reflect the patient's oral dynamics. Now FACEBOW are of 2 types, that is kinematic FACEBOW and arbitrary FACEBOW. Kinematic basically gives you that true hinge axis, whereas arbitrary is a relation or FACEBOWs which will give you an arbitrary value of your hinge axis. Now this relation, what we find, is transferred to the articulator with the help of a FACEBOW, thus relating the maxilla to the articulator in the same way as it is in the patient. Now since I said that the orientation jaw relation is a plane, planes are basically flat section which is defined by at least 3 points in space. That is, FACEBOW captures the relationship between your occlusal plane and the horizontal references. As you can see in the picture, the dots which is marked in the purple are the 3 reference point that we use. That is, you use a 2 posterior reference point and 1 in the anterior reference. So in simple words, kinematic FACEBOW records the true hinge axis, whereas the arbitrary FACEBOW utilizes the approximate points as a terminal hinge axis. Now I mentioned the term hinge axis many times. So what exactly is this axis? Now it is the most retruded hinge position when the condyles are in their most superior position in the articular fossa and the mouth is purely rotated open, and the axis around which this movement occurs is called as a terminal hinge axis. This position is stable, it's learnable, recordable and a repeatable position. Now there are numerous studies which were done to find out what was the exact interincisal opening where this hinge movement occurred. So based on different authors, the final verdict is that this pure rotational opening can occur until the anterior teeth are around 20 to 25 mm apart, or it is in the first 10 to 15 degrees arc of mandibular opening or the closing. This is a very commonly asked viva question. Now why is this hinge axis of clinical use to us? Because it locates the starting point of your mandibular opening and not the condylar path itself. Second, the transverse hinge axis plus 1 anterior point will help you in giving the orientation of the maxilla in space. It records the static, that is the starting point for the functional mandibular movements, and it does not record any centric relation or your condylar movements. Now, what is the reason that there has been numerous studies around this hinge axis? It's because it's a very debatable concept whether hinge axis really exist. If it exists, can it be accurately located, Is there only one or more hinge axis? What are the different methods which can be used to locate the axis? Is this axis clinically useful to us? And if we find an arbitrary point, can it be satisfactory when compared to the kinematic axis? So there are numerous theories or the schools of thought of the hinge axis. This is one of the most important and a commonly asked theory questions and even a Viva chairside Viva question. So there are 4 schools of thought, that is the absolute location of the hinge axis school, the arbitrary axis school, the non-believers, and the split hinge axis school. So let's come to the first group, which is the absolute location of the axis. Here the proponents believe that there is a definite transverse axis and it should be located as accurately as possible. The different findings were that with the aid of the FACEBOW, it was possible to relate the maxillary cast to this axis, and it was possible to replicate the same relationship in the articulator. The next finding was that the mandibular hinge axis coincided with and related to the maxillary hinge axis by means of a centric relation record. The path of the closure on the terminal hinge will therefore be the same on the articulator as in the mouth, and the cusp of the teeth can be placed in such a way so that they will not collide during the intra-border movements of the mandible. The hinge axis is a component of every masticatory movement of the mandible and it cannot be disregarded. And the hinge axis relationship of the articulator must be a duplicate of the hinge axis relationship of the jaw. The second group was the arbitrary location of the axis. So Craddock stated, but the search for the axis, in addition to being a troublesome, is of no more than academic interest, for it will never be found to lie more than a few millimeters distant from the assumed center in the condyle itself. So he says that it can be located through just a simple palpation or by following the convention of measuring of about 1 centimeter anteriorly along a line which is drawn from the upper free margin of the tragus of the ear to the corner of the eye. But this group failed to recognize that if in case the hinge axis of the articulator does not coincide with that of the patient, the path of closure will not be the same. Next were the third group believed that hinge axis is theoretical, but it is of no use to in the practical sense. It is not possible to locate the hinge axis with accuracy. Now, according to Lauritsen and Wolford, if the terminal hinge position could be located consistently within a radius of 1 mm, this would be more acceptable than a location with a variance of 2 mm radius. So also Kurth and Finstein found that any number of points within a range of 2 mm that could be considered a point of rotation or non-movement. Basically this this is a group where they believe that it is impossible to locate the terminal hinge position with accuracy. And then was the group 4, which is the split axis rotation. These were called the transograph men. Basically they believe that each condyle rotated independently of each other. So Slavin stated that by definition an axis is always a line, it's never a point. So again, by definition, an axis is invariably perpendicular to the plane of rotation. So it is perpendicular and it cannot be a straight line. So this means that the transverse axis of each joint is a line, and both of these are perpendicular to the same plane of opening and the closing of the rotation. Now these were the different schools of thought. Basically we locate the hinge axis through the use of FACEBOW. Coming to the indications of the FACEBOW, it is used when cusp-formed teeth are used, balanced occlusion in the eccentric position is desired, when we need a definite cusp to fossa or cusp to marginal ridge is desired, and when interocclusal check records are used for the verification of the jaw positions. It's contraindicated when we use non-anatomic teeth, and if the articulator cannot really accept an FACEBOW transfer, which is used in the denture procedure. Now, Lazari stated few of the advantages. He stated that it permits a more accurate use of lateral rotation points for the arrangement of teeth. It aids in securing the anteroposterior cast position with relation to the condyle of the mandible. It registers the horizontal relationship of the cast quite accurately, and thus it assists in correctly locating the incisal plane, and it aids in the vertical positioning of the cast on the articulator. Now, FACEBOW are of two types. Basically, FACEBOW will orient the condyle maxillar relationship, and it transfers this relation to the articulator. Now, based on how it locates, it can be arbitrary FACEBOW, which can orient the maxilla to an arbitrary hinge axis and transfers it to the articulator. So here the actual hinge axis may not exactly match the articulator. And then is the kinematic FACEBOW, which is also called as the actual axis FACEBOW or the hinge axis FACEBOW. Here it orients maxilla to the actual hinge axis and it transfers to the articulator. So here the articulator axis will be same as the patient's actual hinge axis. Now the kinematic FACEBOW is of three types: TMJ instrument, axiograph and pantograph. And the most important which we use clinically are the arbitrary FACEBOWs. So here, as I told before, that we use 3 reference points, that is 2 posterior and 1 anterior. So based on these locations of the FACEBOW and the reference point, it's divided into fascia type and ear bow type. Now in the fascia type, we use the anterior reference point as the nasal relator, and for the ear bow type, the the anterior reference point is the orbital indicator. Coming to the arbitrary FACEBOW, which is important for us. Arbitrary FACEBOW approximates the horizontal transverse axis and it relies on anatomic average values. Now in this type, the axis is located by using certain anatomical landmarks. So these type of FACEBOWs have something called as a condyle rods, which is placed over that arbitrary landmark, which can give you the center of your hinge axis. This type of FACEBOWs are most commonly used for the complete denture patients, and these give the value of the hinge axis which is sufficiently accurate for most of your diagnostic and the restorative procedure. And a minimum of error of 5 mm from the axis can be expected with these kind of FACEBOWs, and obviously these are less accurate than the kinematic FACEBOW. So the first type of the arbitrary FACEBOW is a fascia type. Here they utilize these type of FACEBOWs utilize approximate points on the skin fascia, that is the skin, over the TMJ region as the posterior reference point, and these points are located by measuring from certain anatomical landmarks on the face. Now the disadvantage of using such a FACEBOW is that the reference point is placed over a skin, so there is it's very difficult and there can be scopes for many errors, and that is why we prefer using a different type, that is a earpiece type of FACEBOW rather than a fascia type. This is one of the BIVA questions. Coming to the earpiece type, here the earpieces of the FACEBOW are placed into the external auditory meatus. So this is more comfortable and more stable, and I don't think there is any scope of errors if such type of anatomical landmark is used. And here the posterior reference point is the external auditory meatus, and here in this type of FACEBOW a special earpiece is required instead of your conventional condylar rods. Now the BIVA question asked here is why earpiece is preferred or is popular than your fascia type. It is because it is simple to use, and it does not require any measurement or marks on the side of the face, and here the scope of errors will be much lesser. Just briefly about the kinematic type of FACEBOW. This is a FACEBOW with a particular adjustable caliper ends which is used to locate the transverse horizontal axis of the mandible. So this will give you the exact location of your hinge axis point, and because it is time consuming, they are indicated when it is very critical to precisely reproduce the exact opening and the closing movement of the patient on the articulator. Coming to the type of the FACEBOW which we use as postgraduates is the spring bow type of articulator. The FACEBOW. It's a earpiece FACEBOW. It is the most commonly used FACEBOW, and this instrument is designed to orient your occlusal plane to the Frankfurt horizontal plane. Again, a viva question. You're relating the FACEBOW while doing your orientation jaw relation to which plane is the Frankfurt horizontal plane by using 3 reference point. Now this is indicated when it is critical to precisely reproduce the exact opening and the closing movement of the patient in the articulator. Next type of FACEBOW is the whip mix FACEBOW. Here again, this is also a earpiece type of FACEBOW, and it has a built-in hinge axis locator. But here, instead of orbital indicator, Nasion relator is used as an anterior reference point. But the problem is this FACEBOW has an extensive chairside procedure. It is also expensive, and so these are rarely indicated for routine articulators with prosthodontic procedures. Another type of earpiece FACEBOW is the slide-matic FACEBOW. So this FACEBOW has an electronic device. It denotes 1/2 of the patient's intercondylar distance, and this particular FACEBOW can be used only with that compatible articulator, which is a Denar articulator. Again, a viva question. Here the posterior reference point is the same, that is your external auditory meatus, and that is why it's a earpiece type of FACEBOW. And here the anterior reference point is, in case of a dentate patient, it is 43 mm superior to the incisal edge of the upper central incisor, and in case of edentate patient, it is 43 mm superior to the lower border of the upper lip in a relaxed state. Next is the parts of the FACEBOW. So in the center you have the conventional FACEBOW. On the left, the first component is a frame. It forms the main frame of the FACEBOW. All the other components are attached to this frame. It extends from the region of TMJ on one side to the another side without contacting the face. Then in the center you can see that it consists of 2 small condylar rods, that is, you have 2 small metallic rods on either side of the free end of the U-shaped frame which contacts the skin over the TMJ. So they are used to locate the hinge axis and then transfer it to the articulator. Now the FACEBOW on the left, which we use, have, instead of this condylar rods, have earpiece that fits into the external auditory meatus. On the right you can see is the bite fork. It is a U-shaped plate which is attached to the occlusal rims, and they are used while recording the orientation jaw relation. Then you have the locking device. This part of the FACEBOW helps to fix the bite fork to the U-shaped frame firmly after recording the orientation jaw relation. Now the third component is the third reference point. It is used to orient the FACEBOW assembly to an anatomical reference point on the face along with the 2 condylar points, which is called as a posterior reference point. Now this anterior reference point varies in different FACEBOWs. Either it could have orbital pointer, which is using the anatomical landmark orbital as the anterior reference point, or it can be of a nose piece, which could be the anatomical landmark, which is the Nasion. So parts according to the FACEBOW what we are using, that is the spring bow. You can see it is the earpiece type instead of the condylar rods. Then you have the locking device, which consists of thumb screw 1, 2 and 3. Each has its own function, again a viva question. Then this is the anterior reference point, that is the orbital pointer. And then this is the bite fork. which is for the edentulous. Here the bite fork is attached to the occlusal rims, and these pointed portion is called as the tines. Again, important viva question. And this rod is the stem. Plane of orientation. So when we have two posterior reference point and one anterior reference point, we get the plane of orientation. Coming to the posterior reference point, very important viva question and a theory question. They are Bayron point, Bergstrom point, Brandnup and Wongson point, Geisses point, Lauritsen and Bodner, and Denard point. Bayron point is a point 13 mm anterior to the posterior margin of the tragus of the ear on a line from the center of the tragus to the corner of the eye. Bergstrom is about 10 mm anterior to the center of the spherical insert for the external auditory meatus and 7 mm below the Frankfurt horizontal plane. Now, an important viva question is that Bergstrom point is found to be the most frequently closest to the hinge axis, and Bayron point is the second most accurate posterior point of reference. Next is the Brandnup and Wongson. It is 12 mm anterior to most prominent part of the posterior border of the tragus on a line from it to the outer canthus of the eye. Geisses point is 13 mm anterior to the anterior margin of the external auditory meatus on a line from the superior margin of the external auditory meatus to the outer canthus of the eye. Lauritsen and Bodner is 12 mm anterior to center of the external auditory meatus and 2 mm inferior to the porion canthus line. And Denard point is 12 mm anterior to the posterior border of the tragus and 5 mm inferior to line extending from the superior border of the tragus to the outer canthus of the eye. Coming to the anterior point reference. So these include the orbital minus 7 mm and ala of the nose, and the nasion minus 23 mm. So orbital is the one which is located by a Hanau FACEBOW with the help of a orbital pointer. Orbital minus 7 mm gives you the true, this plane will give you the true Frankfurt plane. Ala of the nose is nothing but it represents the Camper's plane. And nasion minus 23 mm is used with quick mount FACEBOW, which is your whip mix. Orbital, in the skull, orbital is the lowest point of infraorbital rim. It can be palpated through the overlying tissue and the skin. So this is the anterior reference point that we take during your practical exams. What I would suggest you is, once you palpate this infraorbital ridge of the patient, place an adhesive tape and mark a X over it, so that it will help you when you do your FACEBOW transfer. Next is the orbital minus 7 mm, which gives you the Frankfurt horizontal plane. Here what you can do is, you have to mark the anterior point of reference 7 mm below the orbital on the patient. Or what you can do is, you can place your orbital pointer about 7 mm above the orbital indicator in the articulator. Ala of the nose, as I told you, it gives the Camper's line, which is a line from the ala of the nose to the center of the auditory meatus. Nasion minus 23 mm, it according to Suture, another skull landmark. The nasion can be approximately located in the head as the deepest part of the midline depression just below the level of the eyebrow. So this nasion landmark minus 23 mm landmark is used for the whip mix articulator, and the FACEBOW which is used is the quick mount FACEBOW. Last is the 43 mm superior from the lower border of the lip. Again, viva question. Here, this anterior reference point is used for the as a Denard reference plane. So we know now what FACEBOW is, what are its component, and which is the FACEBOW we will be using for our exam. So let's just go through fast about articulator. So the whole purpose of gnathology is to arrange the teeth in such a way that they work in complete harmony with each patient's natural jaw movement. So to achieve this, we need an instrument that can copy how the teeth relate to the jaw joints, whether they are natural teeth or the artificial ones. And that's why true anatomic articulators were developed to simulate this real jaw function as closely as possible. So to define the articulator, it's a mechanical device which represents the temporomandibular joints and the jaw members to which maxillary and the mandibular cast may be attached to simulate some or all mandibular movements. So basically, this is the transfer that you will be doing in the articulator. Just briefing to the classification of articulator, it is based on the theories of mandibular movements or the occlusion, that is Bonville's equilateral theory, Monson's spherical theory, and Hall's conical theory. So Bonville's equilateral theory basically says that the distance between the two condyles and that of the mandibular central incisors are equal, that is your 4 inch, so it forms a triangle, and an articulator was designed based on that. Monson's spherical theory is that the lower teeth move over the surface of the upper teeth as over a surface of a sphere, the center of which is located in glabella. And Hall's conical theory is that the lower teeth move over the surface of the upper teeth, forming an 45-degree conical surface in which the plane is also inclined to 45 degrees. This is another classification. Articulator is again a major question. And then Rihani has classified it into fully adjustable, semi-adjustable and non-adjustable. And we extensively in our post-graduation use semi-adjustable. Now, what is Archon and non-Archon? The Viva question here can be, how did the name Archon come? So basically it's derived from your articulator and the condyle. If the condylar element is present in your lower member and condylar guide is present in your upper member, it is Archon, and the vice versa of it is non-Archon. Let's see basically why do we prefer Archon over non-Archon. So this is the Archon model. The advantage of Archon articulator is that it is actually anatomically correct, which makes the understanding of your mandibular movements easier as opposed to the non-Archon articulator whose movements are confusingly backward. So this is how the non-Archon model is. As you can see here, there comes a difference in the distance between your occlusal plane and the condyle. And that is why your restoration won't be the same. Next, most important, all about Hanau wide view articulator. Now, Hanau wide view articulator was designed by Rudolf Hanau. It has a fixed intercondylar distance of 110 millimeter, and it accepts the FACEBOW transfer. The FACEBOW that you will be using is the spring bow here. And FACEBOW can be aligned to the Frankfurt horizontal plane. The reference point anterior which you will be using is the infraorbital pointer. I'm sure all of you must be thorough with the parts of Hanau wide view, so we'll just brush through it. It will even help you in your vivas. So this is the orbital indicator, upper member, Bennett thumb nut. Then you have dual and incisal pin, incisal guide table, that's the lower member, and the condylar guidance. There are too many components here, let's see in detail. This is a condylar shaft, centric lock, brass shoulder, condylar element, and condylar guidance. Now let's see about condylar guidance. Always the values are usually asked in your exam, like what are the different values given. So condylar guidance is from plus 60 degree to a negative minus 20 degree, and these condylar guidance is the control center of the articulator, and they actually assimilate the multiple function of your glenoid fossa. So when you do your balancing, see to it that your condylar guidance value is somewhere between 25 to 33. Try to get it inside that, and if it's beyond that, then I don't think it will be very difficult for you to get balancing. Next is a condylar track. This value is from 0 degrees to 30 degrees, and this angle gives you Bennett angle, and it corresponds to the medial wall of the patient's fossa. This is derived by a formula, that is your L is equal to H by 8 plus 12. Again, a popular Viva question is that why it is divided by 8 and plus 12. Next, condylar track. Again, the articulator that you people are using, that is the Hanau's wide view articulator, has a closed condylar track, not open. So, closed condylar track basically means that it rotates in an enclosed housing which stops your condylar element and prevents the accidental disengagement of the upper member. Next, very important, is the centric lock. This is to limit your anterior movement of the condylar element. So the engagement of the centric lock will depress a centric pin, causing it to arrest the condylar element in the centric position. So it is the point from where the protrusive and your Bennett angles emanate. So when it is locked, the upper member is restricted to only an opening and the closing movement only, and releasing this will disengage the centric pin and return the element's freedom of movement on the condylar track. Let's see the next parts. You have resilient bumper, Bennett calibration, protrusive calibrations, auditory pin, condylar shaft, and this entire assembly is a closed track. Condylar shaft, it adjustably slide in the wings of your lower member, and these have been factory fixed by set screws and holds the condylar element. Very important Viva question, what is this part, that is the resilient bumper and its function. So basically this will protectively stop your upper member and rest against the wings of the lower member when fully opening the articulator. And this is your upper member and the lower member of your articulator. Let's see about dual end incisal pin. It has two ends, that is round end of incisal pin and a flat end. Then you have the millimeter calibrations over it, upper member, incisal thumb screw. Then you have zero line and chisel end aligned with the central table, and lower member. So here you can see that there are two annular grooves which appear on this incisal pin. So one is at 37 mm and one more is at 54 mm. This is below the Frankfurt horizontal plane. Very important Viva question again. Each of these lines have a name, that is your Bonbill's line and the Applebaum line. Basically what this helps is these will form an arbitrary vertical landmarks for your alignment of the incisal edge of the maxillary centrals when making a FACEBOW transfer. So one of the way how you can know whether your FACEBOW transfer is correct is when your occlusal plane lies between these two lines. Next is the incisal guide table, which is adjustable. So this provides an independent adjustment of the anterior guidance. Here the value of the incisal guide, that is when you rotate it anteroposteriorly, it is from -20 to +40 degrees. And as you can see, there is a central guiding table here, and this has a width of 5.56 mm wide, and it forms the inclined surface for the protrusive guidance of the incisal pin. Also, along with the protrusive values or the calibrations, you also have this horizontal calibrations on this, that is adjustable lateral wings, and this has a degree of 0 to 45 degree inclines. So let's see this part more in detail. This is the lateral calibration which is there, and these are the lateral wings. They can be adjusted through the thumb nut and the thumb screws, and then you have the platform lock screws. Let's see the lateral aspect of it. This is the lateral calibration value, lateral wing. These are the protrusive calibration, which is done anteroposteriorly. Next is the orbital indicator and the orbital pointer. So this crescent represents the patient's infraorbital notch and is the anterior reference landmark of the Frankfurt horizontal plane. So when it is used with the orbital pointer on a FACEBOW, it provides an anatomical vertical orientation for the upper arch, obviating the use of any average reference lines on the incisal pin. Now here what you need to know is some of the Hanau wide view articulator do not have the orbital indicator. So in that case, how will you know that your orbital pointer is coinciding with your orbital indicator? So the answer to this is that you can in case the orbital indicator is not there, the reference point for you will be the lower part of your upper mounting plates. So if those both coincide, your FACEBOW relation using the anterior reference point is correct. And the last is the mounting plates. Now we know what FACEBOW is, what are the different components, what are the different types of FACEBOW, what articulator is, what are the different types of articulator, and mainly we have studied in detail about the semi-adjustable Hanau wide view articulator. So now let's see how do we do a FACEBOW transfer. So before FACEBOW transfer, there is a very important step, that is the zeroing and mounting, zeroing of the Hanau wide view articulator. So the semi-adjustable articulator starts with basic adjustment of the articulator controls. So that is nothing but the zeroing of the articulator. So why is it done is that we have to minimize the slop or your play between the various parts that may provide difficulty in reproducing the relationship that one is attempting to achieve. So the zeroing of the articulator is done at a manufacturer's recommended position. So for that you need to do your articulator preparation before you go for the FACEBOW transfer. So basically what you have to do in this is that you have to first adjust your horizontal inclination of your both condyle guidances to 30 degrees, and you need to tighten the thumb nuts. Next you adjust the lateral indication of both your condyle posts to a 30 degrees again and tighten their thumb screws. Next, you adjust the incisal guide to 0 and tighten the lock nuts. Adjust your incisal pin to align to the median registration groove. Next, you tighten the centric locks to restrict the articulator to just opening and the closing movement. So before you do the FACEBOW transfer, you need to zero the articulator. So here you can see first you adjust to 30 degrees. And again the Bennett angle also to 30 degrees, and you tighten the thumb screws. Next you adjust the incisal pin to that thickest dark portion which is considered as 0, and see to it that your chisel end of the flat end of the incisal pin coincides with the median registration groove. See to it that your lateral wings and your anteroposterior, that is your protrusive incisal, is also adjusted to 0. Once you do that, you tighten all the thumb screws, the platform lock, and now we are ready for the FACEBOW transfer. So now we know everything. Let's see practically how to do the FACEBOW record and programming of the articulator. So here the bite fork first is attached to the maxillary occlusal rims by heating the tines and piercing them fully into the wax rim. Now the tines shall be parallel to the occlusal plane, and also again a viva question, it should be 3 mm from the occlusal surface and it should not distort the occlusal surface. Once that is done, we add sticky wax to ensure that it is stable in its position. Now the bite fork of your the bite fork shall always be at patient's left, and it should be approximately parallel to the sagittal plane. So this is again a viva question, why is it on the patient's left? It is basically for your ergonomics, and also your articulator is designed in such a way that it takes up when the stem is on the patient's left. You seat it in the patient's mouth. Next you attach the earpieces to the bow using the knurled thumb nuts. Okay, now the thumb screw is finger tightened to retain your anterior patient reference point. So you have in that the transfer rod. So you insert the transfer rod into the bow socket and align the flattened side towards the front and insert to the rubber ring stop. So always see to it, this is a very common mistake during the practicals when obviously we panic. So flat end should always be faced towards the front, and then it should be tightened. Next you loosen all the thumb screws on the bite fork clamp, and then you place it and attach it to the stem. Now you can see there are three thumb screws, that is thumb screw 1, thumb screw 2 and thumb screw 3. Basically each of these have a function. This would be asked in your viva. So thumb screw 1 will secure your transverse clamp to the transfer rod. Thumb screw 2 will secure your bite fork clamp to the transverse rod, and thumb screw 3 will tighten the bite fork clamp to the bite fork stem. Now either you can place cotton rolls between your mandibular occlusal surface or at the underside of the bite fork, or you can place the lower rims and instruct the patient to gently close and firmly support your bite fork in this position. Now you slide the clamp onto the stem, and then you spring open the bow and swing it downward and allow the earpiece to enter the external auditory meatus. Once you do that, loosen the spring-loaded thumb screw that secures the anterior patient reference and rotate it to a proximity with the patient's infraorbital notch, which gives you the true Frankfurt horizontal plane. Once you do that, you tighten the clamp thumb screw in the order, and you see to it that all of these are, we have to raise the U frame until it coincides with the infraorbital notch, and see to it that all of these are parallel to each other and there is no cant. Now you tighten the clamp thumb screws in the order, that is the first one, second one, and then the third one. Once you have confirmed and you check it again, instruct the patient to open and you release the bite fork registration from the maxillary dental arch. So you ask either the patient to grasp the posterior end of the bow or any assistant and release the earpieces from the meatus. Withdraw the complete assembly from the patient with bite fork index rigidly attached to the bow. Next we go to the mounting. You place the mounting jig platform and secure it with the thumb nut. After this, you place your cast holder, and again you tighten the screws. Once that is done, you attach the U frame, and this is why it was necessary for us to attach the flat end which was facing towards the front, so that this goes and secures. So here the mounting plate will be secured to the lower member of the articulator as shown, and your frame will attach to the auditory pins. Alternatively, you can also use the direct transfer jig. Once you secure this mounting platform and the lower member as shown, you can place your cast, and you can also confirm here whether your occlusal plane is correct if it falls between the two annular grooves that I mentioned. You can lift that cast holder support until it touches the surface of your upper occlusal rims and tighten it or secure it over there. Now you place your split cast model and we can go ahead with the mounting. So next is how do we program the semi-adjustable articulator using the extraoral tracing and the interocclusal records. So in this video they have shown from the after mounting of the casts or the occlusal rims in centric, they are showing you this the tracing which is done here. So here they have used plaster and now they are recording the centric. Post this, we have to record the lateral and the protrusive excursions. So you ask the patient to move the mandible towards the right and the left and also to protrude, and the final result is an arrow point tracing which is desired. Again a viva question, what are the different types of tracings and what are the different materials you can use to get these tracing, and everything about the traces that we are using. Also here, protrusive movement, why only 6 mm is, you ask the patient to protrude for 6 mm. So once they got the arrow point tracing, we have to secure that tracing platform with a plastic sheet and make 2 pinpoint holes, one at the centric and other 6 mm on the protrusive path. This is for the interocclusal records. So once that is done, plaster is mixed again with an anti-expansion solution at a recommended proportion and it's placed. First we make the centric interocclusal record by asking the patient to bite, and this should coincide with the centric point which you have got in your tracing plate. Next, we keep that record aside and go ahead with the protrusive interocclusal record. Here again the pin should coincide with the designated point, which is about 6 mm. Now you have the centric and the protrusive, and next important step is programming. So here what you do is you verify whether your centric record is correct. So you remove the split cast from the upper, place your centric interocclusal record, and then you tap the cast to see if the split cast is coinciding or sitting properly in its place. So once we know that there is no gap in the split cast, we confirm that the centric is right and go ahead with the protrusive record. Now here you loosen the thumb screw of your condyle guidance, you open your condyle locks and you seat the protrusive record and you tap the articulator until your reading on the, and you change the reading on the horizontal condyle guidance until your protrusive record is seating properly and there is no space in the split cast. Here you can see that how when the values are changing, the split cast is getting a space. So you need to tap or adjust your values until your split cast is accurately seated. And this is exactly what programming of articulator is. Once you get the condylar guidance, you lock the centric and you check what is the value and derive your Bennett angle. So to summarize, hinge axis forms a major component of every masticatory movement of the mandible. So FACEBOW, just to give a recap, it's basically used to locate your hinge axis, it records it and it transfers it to the articulator. It ensures a correct relation of your maxilla to the hinge axis. Next, you program the articulator which will reproduce the patient's mandibular movement. The hinge axis can be located either precisely using kinematic or it can be by an approximate value, which is by using an arbitrary type of FACEBOW. Now, condyle guidance, I would recommend it should be between 25 to 35 degrees max to max, because balancing will be easier to achieve in this range. Then incisal guidance plus the occlusal plane must harmonize with your condyle guidance. Correct programming will avoid your interferences and ensure long-term comfort and function. So my takeaway message for PGs is that every step here, what I have discussed is an exam and a viva oriented important things. Basically know your definitions, know the values, like how much value is there in the articulator, what if it goes above, what if it goes below. Know the principles, basically know all the parts of both your FACEBOW and your articulator. As a theory point of view, you need to know the FACEBOW, what is FACEBOW and everything about FACEBOW, different points of references, that is your posterior and anterior, theories of your hinge axis, and again articulator is a major question. So I hope I could help you all by giving you certain viva questions and clearing off certain concepts. These are the references that I have taken the information from. The videos which I have shown is available on YouTube and internet, so you can always go back and refer. Thank you so much for listening and all the best for your exams.